The New York City Commission on Human Rights does not provide legal advice. The views and opinions expressed in this program are those of the individuals and do not necessarily reflect the views or position of the Commission. Enjoy the show.
Welcome to Rights Here, Right Now, your quick and easy guide to understanding human rights in New York City. I'm Jose Rios Lua, pronouns he, him, Chief of Staff at the New York City Commission on Human Rights.
And I'm JoAnn Kamuf Ward, Deputy Commissioner of Policy at the Commission. My pronouns are she, her. Each month, we dig in at the radio show into important human rights issues that affect New Yorkers' daily lives and talk about how the New York City human rights law can support you. So this August, we're marking National Breastfeeding Month with a conversation about birth equity, what it means to support parents and caregivers, and why that matters for all of us. I also want to flag it's currently Black Breastfeeding Week, which makes our topic even more timely and appropriate. And we have a really exciting guest expert with us today to share some work in this space. But I want to start with just grounding a little bit about why we, the New York City Commission on Human Rights, are having a conversation about breastfeeding. And it's really for a few reasons. It's because there have been long-term structural barriers to equitable birthing and pregnancy. That's true in New York. It's also true nationally in the United States. And the city human rights law has provisions in it that try to address some of the barriers to equity. So I'll just mention a few of those. The city human rights law prohibits discrimination against people because they are caregivers. The law also has specific provisions regarding pregnancy and lactation, specifically in the workplace. So the New York City human rights law requires employers to make modifications or accommodations for pregnancy, lactation, and related medical conditions, which we'll dive into a little bit today. It requires employers to have written policies that are posted and disseminated. And recently, just as of this year, across New York State, employers are required to provide paid time for breastfeeding and lactation. That's important because it's the anti-discrimination law that's on the books. But today we're really excited because we're going to delve into what this means in practice for pregnant and birthing people, what's missing, and what more is needed.
Yeah, and so we're honored to have Latham Thomas, who spent years advocating for dignity in parenting, caregiving, and reproductive justice. Latham, for folks who may not know your full story, can you tell us a little bit about who you are and what brought you into this work?
Thank you guys so much for having me and for the opportunity to be here. As you shared, I'm Latham Thomas, founder of a global maternal health and education platform called Mama Glow. What we do is primarily train doulas and nurse care managers to improve maternal health care outcomes. And in New York City, that work spans through a bunch of pathways, including our work with the Citywide Doula Initiative, which is funded through the Fund for Public Health, and it allows us to provide doula services to vulnerable individuals in tree neighborhoods, and that's about 33 zip codes have been identified. We're able to provide service provision to families in need. We offer support for people who are unhoused and navigating the shelter system, migrants, teens, folks who are aging out of foster care, and Medicaid eligible applicants. And so really anyone who wants to have a doula can have one through this program. So in addition to the work that I do educating people, I'm really committed to improving maternal health outcomes in a tangible way. And as I think about this time that we're in now and really thinking forward to how to continue to improve the experience for parents and birthing individuals as they navigate feeding and infant feeding, this week is really a powerful one for us to be talking because there are some challenges that people are navigating currently. And now more than ever, it really is important to hunker down on how we can continue to protect populations, including parents and families.
One of the things we're talking about today is this concept of birth equity. And so if we can talk a little bit about why is birth equity such an important human rights issue and why right now it's more important than ever.
I think establishing really what birth equity is also important for people. Sometimes people conflate equity and equality. Equity is really having fair and just access first, right? It's having a starting point that is equal, but also takes into consideration other factors like social determinants of health, housing access, education, job and food security, like all of these factors that can leave somebody behind and mean that they're actually not starting at the same starting point, right? We have people who start ahead because of generational wealth or access or privilege. And so equity is about starting people regardless of where they are in the social hierarchy, is starting them from position where they actually have a chance. And what that looks like is factoring in the social, economic, and the structural factors that impact those populations and make it challenging or even impossible for them to have a fair outcome, right? And so when we're talking about birth equity, we're talking about and really centering people of marginalized identities first. And that means that when we design in that way, that those people actually have a fighting chance. And so what that looks like, I always like to give people the example of the disability justice movement, because I feel like we can learn so much from marginalized groups of how they fought for access. And I look too often to queer and disability groups for these examples, because that's where we find a lot of ingenuity, right, in how people have solved problems. There was a huge debate about whether or not we should put curb cuts into sidewalks. At the time, this was like something that was unheard of. It was like, why would we do this? This is impossible. And if you think about those who are bound by wheelchair or a device where they get to a corner and it really limits their life, right? And what you can actually do when you get to that corner if there's not a way to get off, right? And so it makes your world smaller. It changes your agency and ability to navigate the world. And then when you cut the curb into the sidewalk, think about who else benefits. Not just the person who's bound to a wheelchair, right? Or who is not able to get off the curb easily, but also an older woman pushing her groceries, right? Also a baby that's on training wheels, going into the street. Also, a mother pushing a stroller. It's like that's how we take it so much for granted, but it wasn't designed for them, but it serves them, right? It wasn't designed for my ease when I walk off the curb and I'm dragging like a suitcase or something, right? But I benefit from that ease, right? And so this is how we have to think about designing for the most marginalized. And this is how birth equity works, right? So we make design that's intelligent, that's elegant, and that centers those who are at the, precipice, right? With the most problems and the most impacted. And when we solve for those problems, then those people obviously benefit, but those who are less impacted also benefit, right? And so it makes it a better system all around.
We talk a lot about accessibility in the world of disability, and curve cuts is a great example of like universal design where something that's built for something specific can help everyone, right? And so I often think about it similarly as like ramps versus stairs. And so we talk a lot about how ramps are designed for wheelchair users but it really can help people who have mobility issues. It could help people with strollers. But it also, you don't have to have an issue to use it, right? It's just universally accessible to everybody. And I think what you highlighted in there is, I think when you build solutions from the margins in, you can capture something that works for everyone.
I think, like, where do you start with education and outreach, and how do you access or work with people who may have very good reasons to be a little bit untrustworthy of, nonprofits, or in our case, government?
Grounding in a framework is always helpful. And another piece I think is just really coalition building and building across sectors, across agencies, and really centering people. And so we are always working alongside practitioners and keeping them at the center of the work, as well as families and folks who are impacted. Our first sort of, I would say, anchor, is really addressing systemic inequities, right? And so in looking at that, we think through, okay, who's impacted in the population? Not only are the parents that come, but are the practitioners as well, the doulas who practice, right? And so it means that we are also simultaneously having to address solutions for them, right? To think about like, what does fair and equitable, wage look like for them, and how do we advocate for that? And we worked on the Medicaid reimbursement model with the city, and then also with the governor's office with NICDA, which is a New York Coalition for Doula Access. And that was a piece of that, right? Like making sure that doulas are paid well. When we think about systemic inequity, like we're starting structurally with disparities in birth outcomes, right? And understanding that this is not a biological thing. It's really a social and cultural impact of systemic racism and other inequities that shape what we see happening to a population, right? And so people misconstrue that a particular population is vulnerable because of their biology inherently, because you're Black, this is happening to you. It's not because of race, it's because of racism, right? So we start there. And then promoting optimal conditions for birthing. And so we think about like, what does it look like to imagine care that is quality, that is supportive, that is respectful, that is dignified, that is about harm reduction, right? And moving away from coercion and really like what we describe as like a carceral approach to care, which we see across so many of our systems. We see, this sort of more heavy-handed, systemic, but also one where there's like a clear authoritative figure that you have to sort of supplicate yourself to. It's like if you have fear of police and the systems of policing, oftentimes similar people have the same fear when they're dealing with healthcare and healthcare providers, right? People will say, oh, you have to advocate, and Black women should be advocating, and women of color and all this. And it's like, yes, and it's very interesting to ask people to advocate who have grown up in a culture and a sort of cultural milieu where you are taught actually to respect authority, not talk back to adults, not talk up to authoritative figures, not speak back to the police, like be respectful. So your tone and your tenor is one that's more conservative. And so when you have that opportunity, or if you're in a position where you have to speak up for yourself, you don't know how, because that's not a muscle that you've actually exercised, right? So I think it's really challenging. It's like a catch-22, right? You have to do this, but you can't, right? So we have to sort of remember that that happens for people, that they don't have that flexibility or that muscle memory to do the things that we're asking them to do, which is why it's so helpful to have doulas who are there, who are from their community, who have the lived experience and understand what they're going through, to help them with their approach and learn the tools they need to navigate their care, right? So that's one thing. The other thing is that you cannot be birthing and advocating at the same time, right? You can do one or the other, right? You can either give birth or you can be fighting for your life, right? So we have to like choose what we're actually going to lead people into an experience of, right? Is it going to be one of care where they can just, kind of give themselves over to what's happening? Or is it going to be one of fighting for their life in a system that is failing them in that moment, right? And so I think that that's another piece that we have to just bring into it. So when we talk about creating optimal birthing conditions, we were talking about ensuring that people have the best access possible throughout their pregnancy and postpartum experience, and that we're factoring in the things that may show up along the way in terms of their experiences. And I think when we talk about, sort of birth equity in this instance, we also are couching it in a broader health equity context, right? And really looking at eliminating disparities and addressing social determinants of health, like we talked about before, and anchoring in a community-centered approach, right? Like this is about bringing people who are from communities that look like them, have had lived experiences and lived expertise that's sort of similar. It's a community-centered collaboration, right? Where we bring people together. It's policy and advocacy. It's like having these kind of conversations, right? As we focus on solution and really center the people who are most impacted, and also really building a future. Like I think about how do we use like this approach of like futurism. I always lean into futurism and think about like, how do we use this approach of our literary ancestors, like, Octavia Butler or even Audre Lorde, and how they kind of help us anchor in what's possible for a future. And that's what we have to design too, right? We have to work with people in community, people who are closest to the problem or closest to the solution as well, right? They also know what it is. but they're under resourced in being able to actually do it at scale, right? Like people have always been problem solving. If you really look to community, you always see that they've had approaches, but they just haven't been able to, like, we're outpaced in what's happening to us and how we can actually solve problems as they show up because of systemic inequity, right? And so birth equity is actually basically naming that. And health equity says the things that are structurally challenging that put us so far behind the starting line, even though we do have approaches that have kept us alive, we are not able to implement solutions at scale to actually allow us to achieve broader broader health care and actually sort of nail these disparities. And these disparities exist because we actually know that there are people living a parallel life and have had better outcomes, a parallel life and get better care, a parallel life and may have the same resources access and maybe on paper look the same, but then physically, right, and phenotypically speaking look different. My son, he's 22 now, but when he was little, he used to get childhood seizures, right? And he thankfully grew out of them. And I was talking about how when he had one, I was living in Harlem and I tried to call an ambulance to come get us, right, to get to the hospital, and nobody came. I was like, wow, if I lived in a different zip code, I wouldn't even be worried about this, right?
Right.
Just like understanding that like another mother who may have had a similar experience was living on Park Avenue, they would have come right away.
And part of the reason why this type of episode and these types of partnerships are really important is also recognizing that the birth equity isn't just happening in the actual physical process of giving birth, right? It starts beforehand and there's part of it that goes afterwards as well. And so at the commission, we're really cognizant about how pregnant people experience bodily change. Some may experience nausea, severe migraines, specific physical and psychological impacts that might necessitate a change in work or an accommodation. And then after giving birth, right, new parents, both those who are giving birth and those who are not giving birth, need time away from work to bond with the child, to physically recover, to form those ties as a family. And that's also a part of birth equity, right? Bringing those pieces in together.
And one of the things I think that's so beautiful that you've said, Latham, is talking about how like birthing and raising children is really a community experience, right? But we're looking at a healthcare system where things are very individualized. So kind of, I'd love to hear how you think about that in the advocacy on the kind of the policy side. Like, what do you think is needed to make changes so that we can be more community oriented? And then I think we'd love to hear any stories that you have from people you've worked with. You already shared one about your own experience calling an ambulance, that kind of highlight both some of the barriers out there, but what solutions we can imagine.
Well, first, a framework that we ground the work in, which is reproductive justice, and ground in this broader conversation about our experience along the entire reproductive life continuum. And so the principles are the right to have a child, the right not to have a child, the right to raise that child in a safe and healthy environment. So we should be able to see our children grow into adulthood, and also the right to bodily autonomy and sovereignty, right? And so your right to do anything to your body, and that it's your body and not the body that belongs to the state, right? There's so many ways of thinking about birthing, so many ways of thinking about what happens along the reproductive life course. Even when we talk about abortion is also birth. And how do we handle and support people after abortion and ensure that like people, regardless of what the birth outcome is, have safe and dignified pathways to navigate that experience afterwards too. What does aftercare look like for those people? And so also too, like, how we even design the settings that you go birth in, whether it's a birth center, home birth, obviously, like you can do whatever you want. But if you go to a hospital or a birth center, even the way you're told, like, you can only have two people. Why is it two people? Like our families are not two people. Like I know when I had, like everybody came. When I had my son, everybody came. It was like they were cooking in the, in the front room, and like the TV was on. It was a birth center. And I'm like, how do you tell people who are, from communities that are vast and intergenerational, that they can have two people, right? So you already are designing for and centering a cis heterosexual white couple as the
Who don't want to be with their family as
who
the
don't
as
wanna
the
be
norm. No,
family.
totally. I hear you. Yeah,
But that's who's
100%.
centered, right? It's like that's what we see as like the default, right? Is like it's this type of it's a two-person home, and it's a husband and a wife, right? And that's who's prioritized. And that's of course who you would have there, and then be like a mother or a father or somebody, right? And so we're not thinking about the structures of different communities and how they build family and what family and kinship looks like for those families. So if I have like cousins, or if I have aunties, or if I have whomever, they can't come, right? So we already ground in family separation. Family separation is really common, and it's a really powerful way that it's a powerful tool, I should say, that people use to weaponize and make us vulnerable, and also to coerce people into, making certain types of decisions within their healthcare, is separating them from their family. So that I think about. And I also think about the structures of families here versus other places where we have so many great examples, right, of building family, and building family in ways that are really unique. Like I was talking about earlier, we look so much to different movements like disability justice. We look at the queer community for also how we structure family, right? Like family is so, we learn so much about how to structure family from marginalized communities, right? And so when I look at how, like when we're thinking about how we design and make something safe, we look at people like our queer and trans family members who are denied access, or who are misgendered, or who are called, like, is that your brother or your sister, or who is that? Like the way that those people are treated, we have to think through our design, right? And how they can also feel safe in the birthing experience. And also, are they even considered in the design? So we're always thinking about like who's left out, because as a doula, really our goal is to um, protect your memory of the birth, right?
Mm.
So I have to think about all of the factors leading up to that moment and aftercare, right? In how I design, and also in how I implement my care, and how I approach, your needs. And I think that like what we need, to answer your question about what we need more of, I think it's that there's like more awareness needs to be brought into these spaces. There's human beings that are interfacing with other human beings, and if they have never been around particular groups of people and individuals, it doesn't matter if they took a training, there's a touch point that could take place that could really transform for the better or for worse somebody's experience.
Yeah, we need just more lay educators out there who can like talk about things outside of the context of a training, and can, go to like the cookout or where the aunties are hanging out and have casual conversations where they're sharing education with folks. I am a huge believer in lay educators.
Yeah, I love that you said that too, because the aunties know everything.
Yeah.
And the fact that we don't center the aunties and the grandmas and everybody, and we sort of make it be about, people who are credentialed and educated. And I get that, but also it's like you have the people who've been at like 50,000 births and they haven't done doula training, but you're going to say, "Oh, they can't come into the hospital because they're not credentialed." It's like a form of like soft criminalization, like I was talking about with like this carceral sort of approach, like if you don't have this, then we're going to shun you, or we're going to
Yeah.
push you out. And it's like we shouldn't be doing that. In fact, like we've seen so many amazing global examples, like in Uganda. I love that they had a huge maternal health challenge around there was one little small town that was working on literacy, and they had a challenge with literacy with their midwife community, but also needed more midwives. And
Mhm.
so they were like, okay, we need to train these people, but also like, how are we going to get around the fact that they can't read? What they ended up doing was coding all of the messaging through song. So they made
Mm.
was about singing. They have, so when you see these midwives, they sing everything. They learned all of the pathways for treatment that way. And so they can't read, but they understand. And so you may have elders, right, that like have different capacity now, right? And so how do we use the elders who are here? How do we use their wisdom? How do we use young people who have a different type of handle on technology and stuff? Like, what's their role? How do we also use people who have different abilities? I think there's like folks who have like learning disability who are really, really amazing care workers, right? And
Mhm.
so it's like, not pushing people out, but pulling people in and really looking at their unique superpowers and skills that they can bring in. But I love that you talked about like, the community lay people, because those are the ones who provide the best care, who show up. That's the people that like, if somebody passes away, they're in the kitchen cooking, they're organizing, they're getting right. Those are the folks that we need to actually empower in community, like with these roles, right?
Yeah,
And that's what
absolutely.
we look to a lot, like with the doulas. That's like a lot of that's who they are. A lot of them are these people already.
Yeah, absolutely. And I also want to recognize that, like, even if you have, like, let's say a birthing center that has incredibly amazing policies and practices, we also have to recognize that people experience the exact same location in different ways based on different factors like race, income, and immigration status. Can we talk a little bit about how those factors affect who gets support and who gets left behind in terms of access to service?
Along in the country, let's start first, right? Black women are 3 to 4 times more likely to die during childbirth or due to childbirth related causes than white women. And that's a national sort of like look at the landscape, right? When you go to coastal cities like New York, where you feel like there should be more resources, better support, that number jumps to 8 to 12 times. And people say, well, why, right? And there's many factors. I would like to start with that New York, even though it's diverse, New York is really segregated. And so when it comes to segregation, we're talking about like, how resources are allocated and where, and how easy they are to find. I would say that, in these places, you also have a concentration of wealth, people who have higher education and who have higher economic status, like who have more sort of economic mobility. And what you will see is women, Black women specifically, who are with multiple degrees, like more the higher educated Black women are the most vulnerable. And people are like, well, how is that possible? Well, a couple things. Number one, if you're a Black woman, you're maybe like in your early 20s, late teens, early 20s, you have a baby. Typically, those births go smoothly, is what we see with the data. We see that those births go smoothly, even if it doesn't go as planned. They go smoothly, right? What ends up happening is that depending on your health status and how you start off, the pregnancy, if you start off already with health decline or any comorbidities, then that makes you more vulnerable, right? And so what also happens over time is that you have more exposure to systemic inequity, to racism, to the social as well as structural factors that are working on you since before you were born. So if those factors are working against me before I even got here, and then when I got here, I live under and labor under those factors, right? And those structures, then I age with that weight, with that, which we call weathering now, right? And so over time, weathering makes those people who age, who mature, more vulnerable. What you see is more Black women and birthing individuals having babies later, right? So, like late 30s into early 40s, those people are vulnerable. And not because of their age, but because of all of the other things that they have experienced up to now that also make them vulnerable in terms of their health, right? And then we have and live under also this trope where it's like the strong Black woman, right? So we live under that too, where we're like,
Yeah.
oh, we're strong, we're seen as strong, which means when you go into the hospital, already they perceive you as impervious to pain. So you go in, it's like you're strong. So on average, too, Black people spend 2 hours additionally longer in the ER waiting to be seen than their white counterparts. So these are things that like lead us to a place where, yeah, we're going to experience a different type of care, right? If people think you don't experience pain, if they think that your bodies are like workhorses, if they think that you're strong, if they think that, you're not vulnerable, but in fact, we are really vulnerable, right? And so that's one thing. So we start off more vulnerable, typically because of other health factors, socioeconomic factors also come into play, obviously, as well. And then access is a big one too. And it's not that people aren't going to their prenatal appointments, they're not being heard, right? People are going to their appointments, not able to ask questions, not able to speak about the things that they're experiencing. And so you have somebody who might have a health issue, right? That they're facing, that they know is happening, or that they might be just learning about. And then guess what? They're trying to address it, and the physician may or may not provide them with the resources to address it, or they may not have the insurance that allows them to get the testing necessary to actually see if they have that particular issue. And so if you can't, through procedures and treatments and diagnostics, figure out what's going on, then something that's treatable can become lethal. And what we see is things like preeclampsia, right, where you have pregnancy-induced hypertension, where people don't understand hypertension. Tense is like the main factor in that word. And hypertension is not about eating fried chicken. And I wish people would stop saying that people of certain backgrounds eat a certain way. Everybody eats the same in the United States. Last time I checked, everybody eat the same food. You go to Yankee Stadium, they're eating the same hot dogs, the same chicken
Yep.
sandwiches. Everybody eats the same. Everybody in this country eats the same food. They eat each other's food. So if that was the case, white women would also be dying because of high blood pressure, which they're not. It is not food. It can be exacerbated, right? Because you've had, like salt can exacerbate a situation that's already there. But you're not like, it's not because you ate a chicken sandwich that, that you have a poor health outcome. It is because you're laboring and living under systemic inequity, right? And so chronic stress that is caused by poverty, right? Which is so stressful to live under. Poverty creates so much stress in your body. Literally, you are constantly producing cortisol, constantly producing stress hormones, epinephrine, norepinephrine, adrenaline, noradrenaline, like constantly. And so you have people living with that systemic inequity, racism, all kinds of things that happen in their lives, right? And when we're talking about social determinants of health, we're talking about all the non-medical factors that impact your health outcomes, right? And so housing is stressful for people right now. Freaking a carton of eggs is stressful for people, right? Like all these things can create hypertension. These things can create stress. That these things can elevate your blood pressure. If you're talking about people who are living with domestic situations, which we are always encountering folks who are living in situations where they're not safe, that will raise your blood pressure. So all these things, and we see this happen towards the third trimester of pregnancy. Suddenly someone had a healthy pregnancy and now their blood pressure shoots up. And then they're not monitored. And then you have a health event, right? Where somebody may have, a elevated pressure for a period of time that can lead to a seizure, that could lead to a poor outcome or even death, right? These are things that can be preventable. And we know that 60% of the deaths that we see are preventable, right? When we're talking about maternal deaths. And so why is it that it's happening? Because we're not paying enough attention, right? We're not holding close these individuals and their stories. We're not learning from the stories of loss, right? Which we really need to be, because we're talking about statistics and not individuals. And what we need to do is flip it, where we're talking about individuals and their stories and who they are. So we have a visceral connection to, and a desire to change it, right? You know, statistics, it's like what they say, like one death is a tragedy, but 100 is a statistic, right? And so it's like we can't wrap our head around hundreds of people dying or thousands of people dying, right? We don't understand. We can't like really feel a way. And certainly in a country and in a system that where you are seen as an underclass or you are seen as part of the unprotected class, we are not fighting to protect Black women and birthing people in this way because it's like they're not really a priority, right? You know, if you think about it in the broader landscape, in the broader sort of context of like our healthcare goals, right? They're not at the top of our health our goals, even though when we talk about the feminist movement and other movements we like that are working towards equity and equality, like this should be at the top.
Catching back up to like some of the your framing on the reproductive justice, like, and hearing you say like we know these numbers, right? These are not new in
Yeah.
terms of maternal mortality and birth outcomes. I want to make sure we pick your brain to think about some solutions, and we can start sort of smaller. New York City, I know it's not really small, but that's our universe. Like, what do you think are some of the short and long term opportunities to build some of the concepts of dignity and equity and reproductive justice into the systems we have now, but also what needs to be kind of reimagined?
Well, first, I think it's happening here, which is actually considering birth equity part of the human rights framework, right? Like that, I think is a wonderful starting point, is that so much of this work is siloed, as you know, and how we think about it is that this belongs to this community, this is their problem, right? Not this is a human rights issue. It is. We talked about community, and one thing that is really important to remember is that Black community is organized around matriarchy, and it's organized around, you know, eldership as well, right? And so what happens is that matrilineally, if I could say that 5 times fast, right? Speaking, you have daughters, and particularly birth order is very important because like a firstborn carries so much weight. And but what happens also is that the potential, right, is poured into firstborns, daughters. There's expectation, right? And those people become our aunties, become our grandmothers, right? Become those elders over time. But they take on an enormous responsibility early on. They're adultified very young, right? But also, those are the people that are not becoming elders because we're losing them. And what happens in the Black community when you lose mothers is it disorganizes our community. It disorganizes it. It's like it's disorganized. It's like not just sad or not just, you know, like a devastating thing that happens to a family. It disorganizes the community. And so and I see an example of this in Harlem, where I had an elder who lived in a building. She had a bunch of grandchildren, children, everyone was around. You would hear her voice at 2:30 in the morning, be like, "Is that Miss Rhodes?" Like just yelling at some kids on the corner to get in the house and whatever. She would break up stuff with the gangs and whatever. And when she passed away, it was mayhem. It's like the community fell apart, like fell apart. And she was really and we didn't realize how much of a glue she was. And when I say that, like it's that we lose, right? But we lose that early. We lose those women who will become those people. We also lose the economic potential as well, right? Of that person who went to college and did this and was going to give back to their community, or who is a major source of income for their community. We lose that potential. When we think about solutions, right? I think that there's so many things that we can do to better support community. I know we're talking about Black Breastfeeding Week, and also just like I love to like anchor around some of the amazing ways that we can support now, like literally today, start with families. And, one of the things I think that, again, to think about inclusivity is to start to recognize the different family configurations that exist. In New York, we honor all those families and we see them, whether we see them in ads in the subway, whether we see them in person, whether we see them in transit, or in our schools or in our churches and all the places that we go in the grocery store, we see different family configurations. I think we have to honor them in these spaces, and people should see and find not only literature but also information, regarding their rights, but also like what they have access to in terms of resources. And we're seeing more, like, I think it's really beautiful, like a lot of the trainings that are mandatory that are coming down for a lot of the practitioners working, from community healthcare workers to nurse family partners to doulas. Like, they're learning so much about other types of families, other types of individuals that they may encounter, and how to best support them. I think this is really important. I think from, the point of view of breastfeeding and chest feeding, it's also understanding that, like, people find different pathways to feeding. And we anchor in, human milk being a first food, and that every infant has a right to that first food, and their parent has a right to provide it. We have a lot of baby friendly established hospitals, but I would really like to see people, adequately supporting across the board every person after they give birth in, really feeding human milk first. And not everybody, depending on what type of family configuration you have created, has a pathway to breast milk, right? But if we do a better job of, like supporting our milk banks and also supporting other like outside community-led efforts in ensuring that there's human milk available to infants, then people can actually, of all backgrounds and of all type of family configurations, feed their children human milk. And that's what we should be really pushing for. Formula is available, great, and it's an alternative, when human milk isn't possible. But I feel like we just don't make it an effort to ensure that people have the second line of defense, being milk banking.
Yeah, and I mean, that goes back to the community piece too that we were talking about. And like, I know with my own kids, like struggling to try and breastfeed, being isolated in my house with my husband who didn't know enough to help me really. And like, yeah, there's not a community source that I knew about at that time. I think now
Yeah.
I'd probably know. But yeah, so much of that is about, right, like collectively thinking about how we treat our birthing people and their babies, and what that means for us.
It's like, why are we letting people be alone? Like in Europe, you get a nurse, right? Like one of my clients flew all the way. She's like, girl, I'm not having a baby here. I'm going home, where and my insurance pays for not only my birth, it pays for a nurse to be with me for 6 weeks. She's going to come every day. She's going to cook and help me breastfeed. And she went home and she did that. And it's like, why are we not, you know, it's like it's so much less expensive. And I think that people don't realize this. We spend so much more money on absenteeism of people who don't matriculate back into the workforce, and like all kinds of things that we could just pay you to be home. Paid parental leave has to be at the top of the agenda. This idea that like nobody can get it done, like we need to get it done.
It's a very un-American concept.
So
We were joking before we started the show about, we're talking about anti-discrimination protections. Those are important, and policies in place, but there's some fundamental infrastructure that really is a barrier, I think, to some of the bonding that kind of science shows is really important for family togetherness and bonding.
yeah, but people, yeah, now that people don't want to look at science, but yeah, it's true. But this is it's so it is critical when you think about, if we want to talk about humans, right, and their potential. It is important for the expectation of a competent newborn at birth is to be born into community, right? A newborn expects to be held, not in a container somewhere, held, because it was in a container, right, which was the uterus, it is born. And then the newborn expects extra uterine gestation, right? Because they're born at a size where, their head is at a certain point, it's too big, right? Our pelvises are designed to carry them for 40 weeks, right? And then beyond that, there's reasons for why they can't stay. The placenta calcifies, it's no longer as, a viable source of nutrition. And so you have to have the baby by 40 weeks, or a little longer, up to 42 weeks. But then after that, guess what? It's not like a horse where they come out and they follow their mommy after birth. No, they have to be carried. We're carry mammals. And so if you look at all the other primates that carry their young, they carry them to 5 years old, right? So we're expected to carry them. So newborns expect to be held. They expect to be nurtured. And so it goes against their biology to be alone and to be isolated and to be in a daycare somewhere when we really should be home with and also it goes against ours. And so when people look at what's happening with postpartum depression and anxiety, they don't understand why people need to be bonding at home, not only with their babies, but with their families within a community network. And this is why we saw such a rising and shooting up rates with postpartum depression, anxiety, psychosis, and COVID, because we're telling people to do the opposite of what their actual natural intelligence tells them to do, which is to ground in community, to hover and seek supportive networks, right? And so that's what a newborn expects, right? And so we need to actually build systems around that. And so we're, again, coming back to what we talked about in the beginning, in that universal design, it's about okay, the baby is the most marginalized, right? The baby is the baby has no right. I mean, they supposedly have rights, but the baby is the one that gets all the care in the beginning, right? And while they're in utero, and then when they come out, it's all that goes away, right? The people who are designing systems are taking away everything they can from that infant, and they're taking away everything they can from that birthing individual. And so we, I think, here as a collective and as individuals who are trying to problem solve, have to figure out within what exists in the safety net and what exists within the goodness of our hearts and as community members and as people who can provide service and support, we have to think through how we actually fill those gaps, right? And so that's what I think is possible. And I know it's possible, and that's what doulas are doing. Right? That's what doulas are doing. That's what community healthcare workers are doing. That's what the Nurse Family Partnership is doing. So many of us are working across agencies to fill those gaps to ensure that people have the care that they need.
Latham, we're going to have you back because one session is not enough to even scratch the surface. Before we let you go, there is one question we like to ask every person who's on the podcast. And I think this episode, JoAnn gets to ask it.
Oh, yeah. You have to tell us, what is your favorite New York activity?
Okay, my favorite New York activity is going to our museums. I feel like we're spoiled, you guys. We have some amazing institutions here that people travel around the world to come see. And so if I get uptown, then it's I'm doing the Met, I'll go to the Frick, I'll hang out up there. That's kind of my New York thing. And obviously Central Park, right? So that would be what I kind of do when it's nice out. I really love to do that.
Latham, how can folks who are listening connect with you or learn more about your work?
You can go to mamaglow.com. It's MAMAGLOW.com. And also on Instagram, it's at mamaglow, same MAMAGLOW. And if you just want to see what I'm up to, it's at glowmaven on Instagram.
Well, thanks again for joining us. And for those of you listening, if you or someone you know is facing discrimination because of pregnancy, breastfeeding, or caregiver status, help is available. Visit our website at nyc.gov/humanrights or give us a call at 212-416-0197 to learn more about your rights or to file a complaint. Thanks for joining us on Rights Here Right Now, and be sure to follow and subscribe for more.